All right, so next up we have high-risk patients. So previously we talked about very high risk with recurrent angina or hemodynamic instability. So high-risk patients, so these are quote-unquote early invasive strategy of NSTEMI or unstable angina for PCI. So this is generally ideal within 24 hours of symptom onset. So you can categorize these patients, of course, with the Grace and TIMI score, but also with temporal change in troponin, ECG changes, ST depression, T-wave inversions, high-risk patients with the Grace score greater than 140. Next up, intermediate risk. So delayed invasive can be up to 3 days, so 72 hours. Having none of the above risk factors I spoke with before. However, patients with EF of less than 40% are generally ideal for this intermediate risk category within 72 hours, or GFR of less than 60%, so some stage of CKD. So patients with low risk, ischemia guided, no cath, essentially no risk factors, a Grace score of less than 109, or a TIMI of 0 to 1. So risk and benefit. Sometimes these patients can undergo only medical therapy. So next up, we'll start talking about adjuncts to revascularization. So aspirin has been established mortality benefit. Patients should be loaded with aspirin immediately, and a maintenance strategy of 81 afterwards. So 325 initially, and then 81 day after. Next up, this one's going to be quite a long one since there are quite a few agents. The P2Y12 inhibitor, generally pre-cath load, not done at a lot of centers. There's some controversial benefit, and it can delay cabbage if that's needed. If patients had above findings like multivessel disease. So first up, actually we're already at 2 minutes and 20 seconds, so we'll speak about the next agents. We have prasugrel, clopidogrel, ticagrelor, and cangrelor in the next talk.